Welcome back, everyone. For this lecture, we're going to discuss kind of a hard topic to talk about oftentimes, and it's even a harder topic when you have to respond to these types of calls. But we're going to discuss some of the fundamentals of pediatric patient abuse and neglect. So first of all, let's define some of these terms. Child abuse is any improper or excessive action that injures or harms a child or infant, and this can include things like sexual abuse, physical abuse, emotional abuse, and neglect. Abandonment occurs when a parent or guardian leaves the child without regard to the child's health, safety, and welfare. And patients have relinquished consent authority. EMS providers should render care without consent. Abandonment in general, patients can be found in a home. Sometimes they're left at safe places such as fire departments or any number of places. And at this point, from a legal perspective of consent, parents have relinquished their authority to give consent for the child. And so if you are called to a scene where a patient has been abandoned, then you have the consent to be able to treat, and the law is on your side for that. Just keep in mind that, scene safety is going to be an issue, that caregiver may not have intended to leave the patient for an extended period of time or may return home. So I would encourage you to be vigilant and have additional resources such as law enforcement en route to you. A few risk factors for child abuse. This includes things like younger children, children who require extra attention. So this is often special needs children, those who live in low socioeconomic status. So those who don't have financial means to care for their children are at higher risk. Things where financial problems are present, or divorce or other illness within the family. Drug and alcohol abuse certainly have a correlation with child abuse, and then where there's other types of domestic violence in the home. In suspecting abuse and neglect, you can use the mnemonic child abuse, consistency of injury with the child's developmental stage, history of being inconsistent with the child's injury, inappropriate parental concerns. This can often be over aggressive parenting, or a constant intervention where the parent doesn't want you alone with the patient or is inhibiting the response. You have to be careful with that, though, as sometimes that's a normal cultural response. So you're going to need to, don't use any one of these as an indication, right, that there are a definitive indication that there's an abuse that's happening. But each of these should raise your index of suspicion. Lack of supervision, delay in seeking care. So you see patients with injuries over a period of time, and let's say you haven't seen the patient, the injury looks multiple days old right before you're called, or it's been going for an extended period of time and it's something that should have been treated sooner. The affect of the environment. So things like the parent or caregiver and child relationship to the caregiver is notably tense or notably absent. Bruises of varying age, unusual injury patterns, suspicious circumstances, and environmental clues. Ultimately, you're going to have sort of a red flag that just goes off in your head and is like, something's not adding up here. Unfortunately, not unfortunately, but one of the unfortunate things you're going to have to manage with these patients is you still have to establish a rapport with the caregiver. So when you have times of suspected patient abuse, and whether this is elderly abuse or child abuse or spousal abuse or just any of these abusive sort of relationships or tendencies, your goal should be to get that patient to definitive care, because once you've done that, you have far more resources than you have on scene with that patient. If you suspect neglect, abuse, make sure that you document what you see, pay attention to what's going on around you, including interactions among caregivers, the child's environment, the conditions at the home. And you are a mandatory reporter as an EMS provider. So if you suspect abuse, you're going to have to report that. How you report that varies from state to state, municipality to municipality. That may be that you notify case manager or a receiving facility, physician, RN, charge nurse, or it may be that you have to make an official complaint to a law enforcement division. So you'll need to understand your local regulations on who you need to report to, but you do have to report these. Assessment and management. So involve the police early to secure the scene. You're not always going to be able to do this. oftentimes, and from personal anecdotal experience, when I arrive on scene to an abuse or neglect case, I don't know it's an abuse or a neglect case until I get there and I start the assessment. By that point, you've already got you're sort of waist deep in this thing, and you're there with potentially the abuser, someone who is complicit in the abuse, and your goal then becomes to get that patient to definitive care. And so, establishing the rapport, trying to work with those patients. If at any time that becomes unsafe, though, do remember that your safety and the safety of your partner are paramount. The next safety is the patient, and so trying to coercively get them to allow you to transport that patient, even if they have to ride with you, sometimes is a better situation than remaining on scene or leaving the scene in general. Focus on assessment of the management of the patient. It's not your responsibility to confront the abuser as much as you may want to. There's no good way in that situation, and it goes against everything you're going to want to do as a compassionate healthcare provider. But remember your priority. Your priority is life stabilizing treatment for your patient if they need it. And then the next priority is to get that patient to definitive care, where we have many, many more resources to be able to manage that abusive situation. Be alert for things like a history that's inconsistent with the clinical picture. And this is probably the number one telltale sign, is that you have an aggressive history giver on scene that's insistent on a history that doesn't necessarily line up. That doesn't mean you need to continuously push on the caregiver or push on the historian to give you the truth. You find the truth through assessment, right? History is subjective. Assessment, presentation, signs, and symptoms are the objective evidence to your clinical decision making. So as you find that information, as you find those objective findings, move to that transport stage, and let's try and get that patient to a facility that's appropriate. It's also important to be aware of some of the mimics of abuse. So there are cultural practices and then underlying just conditions that can look like abuse, but they're not. So this is one of the mimics of abuse, and it's a Mongolian spot. It's a birthmark, and it's completely normal. And so sometimes it's difficult to distinguish normal findings from inflicted injuries. And this is why I say, your job is not to confront the abuser. It's to move to definitive care, where better assessments or more thorough assessments, more comprehensive assessments can be completed, and we can really identify what the ultimate cause is here. Other things, things like purpura or petechia, bruising and hemorrhaging under the skin, can mimic bruises, and they're not. They're often an indication of other things, like purpura specifically is meningitis. So be aware of that. And then exposure to the sun can create reactions with certain medical conditions and fruits. And so that's phytophotodermatitis is another mimic there. And then you've got some cultural practices that can mimic abuse. They're not generally considered abuse, as they're not creating harm. They might be uncomfortable for us in Western culture, but we need to make sure that we're assessing the patient appropriately and taking into account some cultural practices. And so on the top here, you can see coining, and that's where a coin is scraped against the skin as part of a cultural practice to treat fever, but it's not harmful to the patient. And likewise, this is cupping, and it leaves essentially what looks like petechial bruising. It's essentially a hickey from a heated cup being placed, and then as that cup cools, it draws suction against the skin and creates that petechial look, or that hickey sort of appearance.